Hello, everyone. Welcome back. Today we're continuing with the neuromuscular conditions, and today we're going to talk about Parkinson's disease or PD. So, Parkinson's affects men slightly more than it affects women, and here are some of the general characteristics of it. So, it's a progressive condition involving the extrapyramidal part of the nervous system, which causes impairment in motor function. So, the reduction in the neurotransmitter dopamine, primarily in the substantia nigra, is a component which is a component of the basal ganglia. However, even though these dopaminergic cells get lost, kind of like the kidney and liver disease we talked about a few weeks ago, symptoms don't really occur until the loss of these is greater than 80%. So some of the symptoms that people with Parkinson's experience are resting and action tremors. And you can imagine, if you're having these tremors when you're resting, you're using a lot of energy when you're not really doing anything. So we'll talk about that when we get to the exercise. They also experience rigidity and bradykinesia. So bradykinesia is just, slower movement, and that can be for gross motor skills or even for fine motor skills. Standing kyphosis with flexed extremities, start hesitation with festinating gait. Now, this is, yeah, like hesitating to start walking, like they want to try to, but they can't. Dynamic postural instability. And specifically, why this is such a problem for this population. The scaling factor, which we'll talk about a little later, the Hone and Yard disability scale, goes up to 5. So if a person has a level of 3, it represents the inability to recover their balance on a pull test, and that increases their fall risk quite a bit more. So, how do we manage Parkinson's? Well, first, let's talk about the clinical classifications of it. So, typically people are diagnosed with this when they're a little over 50 years old, but it can happen anytime, right? So, the age of onset is something they consider. So, if it's less than 40 years, it's juvenile, between 40 and 70, or greater than 70. What their predominant symptom is. So, whether it's tremors, akinetic rigidity, or postural imbalance slash gait difficulty. Their mental status, so if they have dementia or if they don't, the clinical course of the disease, so benign, progressive, or malignant, and then the level of disability using those stages, so 1 to 5 of the Hoehn-Yahr classification. Now, why this is important is because depending on who the person is, kind of like a lot of the other conditions we've talked about, like MS and whatnot, um, they could be at the same classifications, and PD can manifest in many different ways. So for example, if someone is on the clinical course of malignant, then their outlook does not look good. It's a really dire situation. But basically, we use these clinical classifications in order to set a plan for them, a treatment plan. Now, the main way that Parkinson's is treated is through drug management. Now, the medications are aimed at correcting or preventing neurochemical imbalances in relation to dopamine, epinephrine, and norepinephrine deficiencies, and the relative increase in acetylcholine. Now, the most common drug that people take if they have Parkinson's is levodopa, and they take this because it's a metabolic precursor to dopamine. So, of course, if you're having an imbalance of it, you would want to restore it. Um, there are other types. Just levodopa is the most common, the one you're most likely to see. But the other medication that they take, including levodopa, have a lot of side effects that can impact this population, like gastrointestinal upset, confusion, delusional states, hallucination, insomnia, and changes in mental activity. Now, the difficult thing about working with this population is because it's mostly medically managed. There are a lot of issues that arise from it. Now, the main issue that perhaps not us in the exercise science field, but the pharmaceutical companies and the doctors who are working on better treatments. The issue with Parkinson's is um, the effectiveness of these drugs diminishes over time. So, if a drug is working for someone, for example, and helping with all of those side effects, then in 5 years, it may not be working the same way. because the effectiveness is decreasing. So that's one problem. The other problem is that other side effects pop up when people have been using drugs for a long time because of Parkinson's. So long-term use of dopaminergics and monoamine oxidase type B or MOA-B inhibitors often lead to dyskinesias, which is just disordered movement, dystonias, and clinical fluctuation of motor disability. And unfortunately, over 50% of people who've taken medication for Parkinson's for over 5 years have reduced responses to their medications and experience fluctuation of motor disability. So again, not only is the drug not working like it used to when they started, but they're also having those negative experiences to their motor function. Um, so unfortunately, because it's so different for each person, medical treatment is typically trial and error. So they work with their physician to, try a different combination to see which combination works the best, with it unfortunately not being as effective years later. Now, a part that hasn't really been explored at all is how exercise affects drug efficacy. Now, this mainly goes to the fact that, not much is just known about how these drugs are working and specifically how um, absorption is happening. So, yeah, so not knowing how exercise plays a role there is just another realm that really remains unexplored. So, what are the effects on the exercise response? So, there are a lot of other effects that we uh, don't mention here. I'll mention it at the end, though. So, specifically for exercise, motor difficulties can be very unpredictable. So, it really depends person to person, and it depends on the person given, a certain time of day or day to day or week to week. But common ones that we see are freezing when walking and then difficulty stopping ambulation. There's also autonomic nervous system dysfunction, thermoregulation difficulties, altered heart rate regulation and blood pressure control, and postural changes. So all of these can randomly happen. So that's just something to watch out for. Some other issues that they experience are also like the fine motor skills that degrade. So things like, their handwriting gets worse, or they can't use utensils anymore, and they can't use cutlery. So um, all of that definitely affects the well-being of the PD patient. Okay, so what are the effects of exercise training on PD? Well, there is research on it, unlike some other conditions we've talked about. However, according to current research, aerobic training in a Parkinson's population can either improve function, fail to affect function, or reduce function. And that's very inconclusive for us. So thankfully, a lot of other research is being done on how exercise can help with the PD population. But as you can see, it's not well known. Um, Now there are three specific things related to PD, that I guess follow from it. So you have direct, indirect, and composite effects of Parkinson's. So the direct ones are basically those that occur directly because of Parkinson's. So the stuff like, the tremors and the rigidity. Indirect is more so like the aerobic deconditioning that comes due to the tremors and due to, rigidity or freezing gait or whatever they may be experiencing. And then composite effects are a combination of the direct CNS changes and compensatory musculoskeletal symptoms, such as a change in axial mobility and balance problems. So exercise most likely cannot help with the direct ones. So like the specific symptoms that come from PD, but they can impact indirect or composite effects of PD. And I mean, we've talked about it this whole semester, right? Like you can help for deconditioning, even if you're not helping specifically for um, the specific symptoms of PD. So again, because like the whole medication realm is really confusing and it can really differ in patients, trial and error is what's really needed for exercise training for the specialist. So little things like if they change their medication or if the dosing changes or something like that, all of that can affect exercise and whether that helps them or does not help them. Also, this exercise specialist needs a mastery in the art of exercise management, if you guys remember from one of the first chapters that we ever looked at. So this population, more than a lot of others, really needs to yeah, master that. Okay, so what are some recommendations for exercise testing and training? So again, you use the scale, the Hone and Yahr scale. So if they're class one and two, then they're basically similar to, just the general population, and you can follow ACSM guidelines. It's perfectly fine. However, if they're class three or higher, use the basic CDD4 recommendations and use some modifications. And these are the following modifications. So test for musculoskeletal aspects, gait, and physical functioning for activities of daily living. Now, some specific ones to look for are the pull test, again, just to assess fall risk, time tandem stand and 360-degree turn, functional reach or a chair sit and reach, reaction time, gait speed, timed walk, walking cadence, and step length. Additionally, sit to stands are also helpful. Now, these are just some minor modifications, but they can really give you some good insight on how to work with this population, what to focus on. Some considerations that you should take for this population is that the prevalence of cardiac dysrhythmias is pretty high. So just watch for that, especially if you're going to use, ECG leads and all that. You might get some interesting readings. Um, all exercise should be started 45 to 60 minutes after the medication has already been taken. And then use caution after a change in medication because it could be really, really different and unpredictable. So those are just a few things to watch out for regarding testing and training. And now, I just have two tables to share with you guys. So these are directly from the book, but these are some considerations to take in Parkinson's. So, um, if there are some balance issues with this population, which, depending on the scale, they may be, using a harness on a treadmill is probably the safest bet. However, as it notes here, some patients can jog safely, so it is very patient dependent. For exercise programming, increase the dose very slowly, and duration and intensity should receive equal priority. Now, for some orthopedic considerations, joint dysfunction is common if they're over 50 years of age, and part of that is just because of age, but part of it is it could also be their history, if they've been physically active in the past or not. Um, yeah, there's some caution against overuse syndromes from exercise training, and then dystonia and dyskinesia can exacerbate joint degeneration. Now, some of the symptoms I listed for the drugs talked about sleep. So, painful nocturnal dystonias can interfere with sleep, and vivid dreaming may occur. So, that just watch out for that. On the psychological end of things, depression is common. Mask-like facial features make it difficult to read emotions and feelings, and people may feel vulnerable when off medications and invincible when on them. Another note here is sometimes, we had that category of, whether they have dementia or not. Well, for the people that don't, having Parkinson's is especially difficult because it may affect, their speech, it may affect, like I mentioned, their handwriting. It can affect stuff like, wearing and dressing themselves. And if there isn't cognitive dysfunction associated with that, that could be really frustrating for them. So just note that as well within the psychological realm. Regarding metabolic, high resting metabolic rates are common, mainly because of those tremors during resting time. And exercise training may alter medication bioavailability, but again, we don't have conclusive results on that. GI discomfort is a common side effect. And then for the autonomic, kind of like MS, sweating may be absent, but improve with exercise training with an increased risk of hyperthermia. So again, just their heat regulation is not what it should be because of these CNS alterations. And now here we have some suggested training activities for Parkinson's disease. Now I won't read every single one of them because I think they're just better, if you are actually working with them, you can pull it up and use them. Um, but yeah, a main goal here is to help them maintain their function, and these are just some tips that you can use. Now, another thing that I want to mention here, and then we'll be done with this chapter, is thankfully a lot of research is being poured into understanding Parkinson's disease and different ways to help. Now, the lab I came from for my master's back in California, they do a lot of research with things like virtual reality or augmented reality, AR, which is not as common, even though I think it's a little bit cooler. And one of the things that they were testing out when I was there, and they're probably going to roll out soon, is if you can use stuff like VR or AR to actually help this Parkinson's population um, kind of overcome the freezing gait or the like not being able to initiate it. So what they would do, interestingly, is they would either, well, they tested this out with a control population, so I don't know how it works with for Parkinson's, but the idea was maybe you can give them some other thing to help them guide their walking so that, they don't freeze up. So one of the ones was playing a metronome in their ear. So, just on beat, try to walk. Another one was where the system, whether VR or AR, would visually print like these marks on the ground that you'd have to hit with your foot. And maybe that just drifts their attention away from whatever is causing the freezing gait to happen, or the fascinating gait to happen. And the other one was combining the two. So what if you combine both visual and auditory? So, yeah, interesting stuff is happening in Parkinson's disease research. And another note here that may be helpful for you to use is sometimes um, Parkinson's patients may have trouble walking, and maybe they're in a really bad, like little segment of the disease where it's affecting their walking and they can't walk without assistance. However, they're perfectly fine on a cycle, or they're perfectly fine climbing stairs. And I've even seen a video of someone with really severe Parkinson's who gets on a bike and just it's as if there's nothing wrong. So, all that to say, that you can find other types of activities other than walking if that is like a special problem for the day that you're working with them. But yeah, that is what I have for Parkinson's, and yeah, I'll catch you for the last two lectures of the semester next week. Have a good one.